Hello, everyone. My name is Sanjay Malia, and I'm professor and chair of oral and maxillofacial radiology at the UCLA School of Dentistry. It's really a pleasure and honor for me to speak to you today on CBCT imaging in endodontic practice. And I have on the line also with us Dr. Sam Katchman, who's associate professor at the Department of Endodontics at UPenn. So with that, let's go ahead and start our course. And what I am going to do is uh, identify for you what are the aspects that we're going to cover. Today, we're going to talk about imaging the endodontic patient predominantly using cone beam computed tomography. And we're going to discuss when is it that you'll use cone beam CT and why is it that you want to use cone beam CT in certain cases. We're going to look at historical, clinical, and radiographic information. And we're going to use that information to sort of synthesize diagnoses and treatment plans. And we're going to look at how CBCT contributes to processes in endodontic diagnosis and treatment plan. From a radiological interpretation, what we're going to do is we're going to look at how we establish a diagnosis, how we assess the morphology needed for treatment planning, and also we're going to talk about, in certain cases, how we look at incidental findings and manage those. So with that, I'm going to start right away with looking at the goals of imaging an endodontic patient. So we have a patient who has an endodontic symptoms of potential endodontic origin, and we are imaging the patient. And our goals of imaging the patient are we want to assess the root length. We want to be able to look at the periapical structures. We want to look at the patency of the pulp and the morphology of the pulp and the roots. And most importantly, we want to assess the proximity of those roots to adjacent vital structures like the inferior alveolar canal. Now, most of these diagnostic tasks we have been able to do with periapical radiography. Periapical radiography, as you are familiar with, has a high resolution. It allows us to look at the periodontal structures in very good detail. However, there are several limitations of periapical radiography, in particular from an endodontic diagnosis and treatment planning point of view. One, it has limited coverage. Second, it is a two-dimensional image, so the three-dimensionality of root morphologies, dilacerations, and pulp relationships are not really portrayed on a periapical radiograph. And periapical radiographs have geometric distortion, so you cannot really rely on the measurements that you make on a periapical radiograph. Now compare that to CT imaging. CT imaging is three-dimensional imaging. It provides you imaging with no geometric distortion. The anatomic coverage that you need can be customized. It can be made a single tooth or a few teeth, or it can be made the entire craniofacial complex. And most importantly, since it's a three-dimensionally acquired volume, you can reconstruct that image volume in any plane, which means that you can look at all of those variations, all of those morphological factors that we want to assess in radiography. You can reconstruct that image in any different plane and be able to look at those morphologies and the variations. So let's look at CBCT machines in general. And what I have for you here are two CT machines. One is the Accutomo 170, and the other one is the Veraview Epox X800. The difference between the two, one is a dedicated CT unit, and the other one is combined with a panoramic and a CT unit, with a panoramic. And in some cases, it can be combined with a cephalometric unit. When we look at the CT images from these, for most part, they're going to be equivalent in image quality. There's some differences in the image quality between the two units, but for most part, when we're looking at the images today, they're going to be equivalent. The differences that you will consider for your clinic will be really depending on the use that you have, the numbers of fields of view that you need, and the floor space that you might have available for it. So let's look at one important characteristic of cone beam CT units, and the characteristic of cone beam CT units very relevant to endodontic treatment. And that's looking at the field of view. When we're looking at endodontic diagnosis and treatment planning, we want to make diagnoses of images with high resolution. And that high resolution is provided to us by fields of view that are smaller in size. So when we're looking at CT images for endodontic diagnosis and treatment planning, we typically are imaging them with a field of view of about 4 by 4 centimeters or 6 by 6 centimeters. If you look at that size, that's a little, 6 by 6 centimeters is a little bigger than a periapical radiograph, about 1.5 times a periapical radiograph size. And so it is providing you still a limited volume, but it's providing you images at a high resolution. So let's take a look at CT images, and this shows you CT images from a phantom that are taken with different fields of view. This is taken with a smaller field of view or a limited field of view, and here you can appreciate the details that you see here. As you start to go to a higher field of view, you start to lose those details, and those details are important for us in terms of endodontic diagnosis and treatment planning, where we need to discern the periodontal ligament space, we need to identify the pulp canals, and we need to get a better estimate of root morphology. So let's look at these two images right here. On your left-hand side, you have this 4 by 4 centimeter field of view. And here you can appreciate a lamina dura and a PDL space that goes around this premolar, and you can see it through the entire length of the root. The same patient, but imaged with a larger field of view, you start to see that you lose the resolution of that periodontal ligament space. In areas where it's much thinner, you cannot discern that periodontal ligament space as well. And the details that you had of the pulp canals, you also start to lose when you're looking at a larger field of view. So from an endodontic diagnosis point of view, one of the things that you want to be able to do is to be able to take images that are in a limited field of view so that they will give you a high resolution image that will allow you to look at the lamina dura, that will allow you to look at the periodontal ligament space, and most importantly, allow you to look at the anatomic boundaries, both of the tooth and of adjacent structures around, and make those relationships to the apex of the tooth. So if you are doing CT imaging in the US, you will code the images, and there are certain CDT codes that you can use for CBCT. And the CDT code that you use for limited field of view CT, which we use for endodontics, is D0364. Next, let's talk about radiation. Radiation dose is something that we often consider when we are imaging our patients. And there's a lot of concern about radiation dose, in particular with CT, and in particular when we are radiating children. But let's look at radiation dose from a practical perspective and make sense of its impact on the patient and impact on selection of radiography for that patient. What you do see here on this graph on your left-hand side is the effective dose. And that effective dose is given in a unit called as sieverts. Now, it's difficult for a patient to understand those units. And so in order to help patients understand that, there are sort of benchmarks that show you one level, level 2 and level 3, where as you go from one level to the other, the risk level sort of increases. Another way you can look at radiation is to compare it to natural background radiation. And that's what's shown here on the right-hand side. On your right-hand side, what you do see is the natural background radiation and the equivalent of that. So 1 day of natural background radiation, bite wings are a little less than 1 day of background radiation. Let's take limited field of view CPCT, which we do for endodontic diagnosis and treatment planning. The CTs that we do for endodontic diagnosis and treatment planning are going to give about less than a week of radiation, background radiation. So they're not high dose procedures. Compare them to other procedures such as chest x-rays and mammograms, which have much higher radiation dose than the CTs that we're doing in endodontic diagnosis. Another way to sort of convey radiation dose to patients is to provide them a example of something that they can relate with. And one example that you can give patients is air travel. When you do air travel, you're at an altitude and you're exposed to cosmic radiation, very much like X-rays. But let's take a flight from Los Angeles to New York City. That's about 25 microsieverts. And let's take a flight from Los Angeles to Osaka. That's about 100 microsieverts. You know, I really wouldn't be worried about these doses when if I were to take any of these flights. And so from a point of view of radiation, it's important for patients to understand and for you to understand that these are low radiation dose procedures. So where does that low radiation dose procedure really come into play? That low radiation dose procedure comes into play when you are selecting a patient for radiography. When you are selecting a patient for radiography, one of the things that you want is that the benefit that the patient will get from that imaging, from that CT imaging, should outweigh the risk. As we just described, the risk from a CT image taken for endodontic diagnosis treatment planning is very low. So which means that you don't have to put as much more benefit. And with that, you can really outweigh the risk. And so the benefits that you are providing your patient is to be able to detect apical periodontitis beyond what can be detected in two-dimensional imaging, to be able to evaluate the tooth and a variety of features of the tooth and the periapical structures in a manner that you cannot do on a two-dimensional imaging. So all of those benefits, really, when you add them up, are way more than the risk that is associated with that CT image. So what this drives home an important point is that if you evaluate your patient clinically and you come up with the need for CT imaging, then really that need for CT imaging is justified in itself because you have made that decision that the CT imaging is likely going to provide benefit to the patient. So how can we select a patient appropriately for CT imaging? Well, the American Association of Endodontists and the American Academy of Oral and Maxillofacial Radiology have sort of made that task easy for us. What they've done is they've created guidelines and they've provided recommendations. And there's a total of 14 recommendations. And these recommendations will address a variety of clinical scenarios. Patients who are presenting with contradictory or non-specific symptoms, patients who might be presenting with unusual number of canals or variation in the number of canals or a calcification of canals, patients who might present with non-healing endodontically treated teeth, where we might suspect root fractures or we might suspect certain treatment complications. Or in cases where we have deemed that traditional endodontics is not going to be sufficient and we're planning surgical endodontics. And cone beam CT will allow us, as you'll see in both the examples that we give, it will provide value to planning surgical treatment. And there are certain special situations such as placement of implants, patients who might have dentoalveolar trauma, root resorptions, and to assess treatment outcome. So all of these situations, there is a value for CBCT in these situations. And the AAE, AAOMA recommendations allow us to select a patient appropriately for CT imaging. So let's start to look at some of those recommendations, and we'll go through just a few recommendations. Let's take recommendation 2, a frequently applied recommendation. And it says that you should consider CBCT in a patient who has contradictory or non-specific clinical signs and symptoms, either with untreated teeth or with previously endodontically treated teeth. So here we have a clinical scenario. We have a patient who has come in with symptoms which seem to be contradictory to the two-dimensional imaging that we have, or who might have symptoms that are somewhat non-specific in nature, and the two-dimensional image just has not provided us any information to make sense of those clinical presentations. So why would we use CT imaging in these cases? In these cases, you would use CT imaging because we know that CT imaging can detect periapical radiolucencies much better than intraoral radiographs. It also allows us to look at the length and the density of the filling materials much better than we can do on periapical imaging. It allows us to identify those additional and accessory canals, which might be the cause for that patient's contradictory symptoms. And most importantly, it allows us to make the distinction between those cases where we can clearly identify an odontogenic source, and in those cases where we cannot identify an odontogenic source, and we can appropriately refer the patient for management for non-odontogenic causes of that patient's symptoms. So let's look at a study here. This was a study that was done in dogs. And what they did in this study is that they induced apical periodontitis in the teeth. And then subsequently, they did periapical radiographs and they did a cone beam. And then the teeth were extracted, and then, the teeth were then, that entire jaw was then fixed, and histology was done. And so what we do have here is a histological gold standard, and we are going to see how does CBCT and periapical radiography match up against that histological gold standard. And from the data, you can see that the sensitivity of CBCT, the ability of CT to detect apical periodontitis when it is present, was vastly superior to that of periapical radiography. And that's the reason why CT imaging makes a lot of sense in those patients who might have those contradictory symptoms or non-specific symptoms. So let's share some experiences from UCLA. In our graduate endodontic clinic, we went back and we looked at cases where CBCT had been done. And we went back and we asked, what was the contribution of CBCT to those patients? What did the value of CBCT provide? What was the value that CBCT provided in those cases? And what you can see is in these particular scenarios, in those scenarios when we applied recommendation 2, where patients had presented with sort of non-specific symptoms or contradictory symptoms to periapical radiographs, we found that when we used CT, we changed the diagnosis in more than half the patients. And more importantly, in close to about 86 to 90% of the patients, their management changed. Right? Which means that value of CT was tremendous. It allowed us to make changes to our diagnosis, and more importantly, it allowed us to change the way the patient was managed, which is very important. Right? So CT having a value here is this really is a good test for that value of CT. It's telling you once you take the CT, how beneficial was it? What did it do to the diagnosis? What did it do to the treatment plan? Did it have any value? Let's look at another recommendation here. And this is recommendation 6, and also a very frequently used recommendation. And what this recommendation states is that if your clinical examination and intraoral radiography are inconclusive for a suspected vertical root fracture, you should do CBCT. So let's look at what vertical root fractures are. They're root fractures within the root. They're longitudinally oriented. They may be complete or incomplete in a sense that they may not necessarily extend through the entire width of the root. They can start at the root at any level, which means that the manifestations that you see radiographically can be at any level of the root. Most often, these tend to be in a buccolingual direction, and we can look at some examples of that. Vertical root fractures occur overwhelmingly in previously endodontically treated teeth. And so you should consider, whenever there's an endodontic failure, you should consider the possibility that there might be a vertical root fracture that's contributing to that failure. Let's look at the roots which are most commonly affected with vertical root fractures. It's the mesial roots of the molars, of the mandibular molars and the maxillary molars, the roots of the maxillary premolars, and the mandibular incisors. So when we look at vertical root fractures, how do we know that there's a vertical root fracture? What's our gold standard for that? One gold standard is surgical exploration. And so the clinician would elevate a flap and then view the fractures directly onto the root surface. But that's limited because you can view only the buccal and the palatal root surfaces and not really the furcational root surfaces. And so this surgical exploration might underestimate vertical root fractures. On the other hand, you can look at that, you can determine the presence of the fracture following extraction of the tooth, but the extraction of the tooth in itself might cause the fracture, which will cause you to overestimate the root fracture. When you're looking at root fractures on a CBCT, it's important to remember that we do not see these fracture lines directly. For most part, these fracture lines are not visible. And that's because there's very little space between those two fractured fragments, very little separation between those two fractured segments. When the separation occurs, you will see the fracture. But for most part, those fracture lines are not separated. And so you may not be able to see a fracture line directly. How then does CBCT provide any value? And that's because we do not see the vertical root fracture, but what we look at is the pattern of bone loss around the root that is subsequent to a vertical root fracture. And using that pattern of bone loss, we sort of infer whether there might be a root fracture or not. So let's look at what root fractures will manifest on a cone beam CT. A very classical example here is where you have a radiolucency along the root surface, and it's just adjacent to the post of the restoration. And likely placement of the post or continuous force along this area might cause a fracture, and that fracture then leads to a conduit. It's an inflammatory conduit that goes from the obturated space to the periodontal ligament, providing you a conduit for development of inflammation within the periodontal ligament space and that radiolucency to appear. The other appearances of vertical root fractures are where you'll see bone loss along the mid-root level. And remember, as I indicated, those fractures occur anywhere along the root level. So if they are along the mid-root level or ending along the mid-root level, they can cause inflammation in that area. If they extend along the entire length of the root, you might see radiolucencies around the entire root, surrounding the root in a circumferential fashion. I like to look at vertical root fractures on axial images. And when I look at it on axial images, I look at the fracture, I look at the shape of the root, and I look for a periodontal ligament widening that is sort of asymmetric. In this case, I look at this periodontal ligament widening here, and I'm going to make an assessment that perhaps there might be a fracture here, which is why you have a conduit of inflammation that gets to the PDL. When we look at this fracture line here, there's possibly a fracture that goes in this direction, which is why you have periodontal ligament inflammation at either ends of that fracture line. And this appearance sort of will suggest that there's a fracture that's sort of going along this direction, which is now providing you that periodontal ligament inflammation at both ends of the root. And so when we do not see the fracture line directly, but what we will see is periodontal ligament widening. And then we use the pattern of that periodontal ligament widening to say, is there a fracture? And if that fracture is there, how is it complete or is it incomplete? Now let's go back to looking at the value of cone beam CT for those vertical root fractures. When we did CT for patients who had suspected vertical root fractures based on clinical examination and intraoral radiography, we found that management of these individuals changed in about 88% of the time. A huge number of patients were benefited by having that CT. So in those patients, if you did not have the CT, the management would not have changed, and that you would be treating something that did not need to be treated, or you would be treating something inappropriately, right? And so here, having that CT provides tremendous value. It provides you information that allows you to make a change in the management of the patient. And this, in this case, with vertical root fractures, it's occurred in 88% of the patients. So really, that CT is providing tremendous value in these patients. Next, let's look at recommendation 9. Recommendation 9 indicates that if you have a patient who you're working up for possibly for surgical treatment planning, then you should consider CBCT imaging. And that CBCT imaging is important because it will provide you a good amount of morphological information that you will not get on two-dimensional imaging. So let's look at a case here. This is a case, there was an endodontic failure, and there is, as you see, on the periapical radiolucency, on the periapical radiograph, a periapical radiolucency. Let's look at that cone beam that was taken of that patient in more detail. You can see the extent of that radiolucency much better, the size of it. But most importantly, from a point of view of morphological relationships, you can now estimate the distance between the root apex and the cortex of the bone. You can measure where that root apex is relative to the crest of the alveolus. So you know these surgical area where you might need to go, where you would need to have your surgical access. Right? It also allows you to identify proximity to certain vascular and neurological structures. For example, here, one of the things that we can see is the mental foramen. And identifying that mental foramen in close proximity and that inferior alveolar canal as it courses through adjacent to that root apex is important because there is a risk that is associated with damage to those structures. But beyond that, even looking at the region of that mental foramen, it's important to recognize that when you are doing surgical treatment, you will be elevating a flap, and you should know the location of that mental foramen relative to the region of surgery that you are performing. Let's look at how CT performed when we applied it for pre-surgical treatment planning. We found that in close to about half our patients, we were able to change treatment planning, and that management changed in terms of the approach that we did, or the type of procedure that was done. Right? Recommendation 12 looks at resorption, internal and external resorption. Again, a situation where CT provides tremendous value beyond that provided by intraoral radiography. And so when we're looking at resorption, one of the things that CT allows us to do is to say, is it internal versus external resorption? Where is that resorption? Where's the resorptive cavity relative to the alveolar crest? Is it supracrestal or is it subcrestal? And if it's subcrestal, how far subcrestal does it extend? Because these are questions that you will ask that impact the management of the patient. If it's internal resorption, you want to know if it has extended onto the root surface and caused a root perforation. And if there is a root perforation, how big is that root perforation? If it's external resorption, you want to know how deep into the dentin has it gone in? Has it involved the pulp? And finally, the extent of resorption, you want to know, is this tooth restorable? So all of these features that we are seeing with these features that are listed here, you will be able to identify on a CT image. While as in the previous one, you see a two-dimensional image, which will not necessarily allow you to make all of these assessments. When you do three-dimensional imaging, the CT imaging, it allows you to assess the relationship to the alveolar crest. It allows you to assess the extent into the dentin, its proximity to the pulp canal, its location, and the overall extent of root resorption that has occurred. When we applied CT imaging to patients who had resorption identified on periapical radiography, we found that management changed in more than 50% of the patients. And that again is the value of the information that was provided in terms of the location of the resorptive cavity and its extent. Okay. So beyond this, I think there are other situations where CT provides tremendous value. And a case that I have here is one that where a patient who had prior endodontic treatment was reporting back with pain in the area, and pain that did not subside. And what this case represents is a case where it's more complex than an endodontic failure. It's in this case, one of the things that we do see is that periapical inflammation, relatively large, has now spread beyond the confines of the periapex, and these arrows are pointing to periosteal bone reaction, which means that this inflammation has gone beyond the cortex and underneath the periosteum. What that represents is a case of osteomyelitis. So what that represents is, yes, still an extreme manifestation of periapical inflammation, but something that now perhaps might not be managed with conventional endodontics, something that we need to manage with high-dose antibiotic therapy, and perhaps with extraction of those teeth if we cannot curtail that infection. Right? And so having that sort of information is very important, because it allows you to make decisions that are important for treatment of the patient. And in this particular case, it allows us to make an assessment that really we might not be able to manage this case endodontically, that we would need to refer this from a surgical point and be able to have that osteomyelitis managed. Right? And so with that CT imaging, what the main points I'd like to drive home is that it's an imaging modality that's providing you with a lot of information. In terms of endodontic evaluation, it's giving us the information on the presence of apical periodontitis, which often might be obscured on a periapical radiograph. It's allowing us to look at the extent of apical periodontitis, which is an important feature for prognosis of the patient. It's allowing us to look at the morphology of the tooth, the patency of the pulp, the number and course of the canals, and the proximity to vital structures. All of those are features that are very important from a treatment planning point of view. So combined, when you take all of this diagnostic and treatment planning benefits of CT imaging, they really outweigh the risks from that CT imaging. And so if you apply CT imaging appropriately, really it's beneficial for your patients, and you can maximize the diagnostic yield that you're going to get from that imaging. Right? So with that, I will stop there and hand over the mic to Dr. Katchman.
Thank you very much, Dr. Malia. Let me get into my presentation. Thank you very much, everybody, for joining us. And I really am honored to be on the same platform as Dr. Malia, and I enjoyed your presentation very much. And I'm going to start with your initial slide that talked about the different recommendations. And basically, I'm going to discuss each of these with several cases. So my name is Dr. Katchman, Sam Katchman, and I'm a professor at the University of Pennsylvania, part-time, but I have 4 private practices throughout the greater Philadelphia area, and I'm doing a lot of cone beam technology throughout every day of practice. And as Dr. Malia pointed out, the value is just unbelievable. So let's start off with some interesting cases. And first, when you get these cases, and I'm going to often say when the patient came to me, it comes from dentists that are, says below here, I'm moving my bar ahead, sorry about that. So the patient had no probings, patient's in pain, and the dentist can't find anything wrong. A lot of times these cases end up being extracted without even the opportunity for me to be able to take a look at the patient. When I did the cone beam, you can see that there was a palatal perforation from the post, and the lesion was in the furcation, unable to be seen on the periapical film, also without probing. So I decided that I was going to go in and attempt retreatment, explaining to the patient that if I can get this post out, and it was a fairly short post and easy to remove, and I could pack some bioceramic putty to seal it and try to sterilize that area, that we had a chance to save the tooth, because there was no mobility and the patient really wanted to try anything and save the tooth. But I wanted to know what was happening ahead of time. I don't want to be surprised. And that's the beauty of the cone beam. As Dr. Malia pointed out, it helps us with our diagnosis, and we're able to determine ahead of time so that you don't get stuck starting to treat it and say, oh, I didn't realize maybe there's this, or I found something that I didn't anticipate. So here we have a case where you see the central incisor and the post is literally floating in space. And we're tempted to say, well, this is an easy retreatment, but there's also a periapical lesion. Maybe I'll go in surgically. And when you look down here in the lower left, the root is actually almost 45 degrees to the shape of the crown. And as you can see here, there's a palatal perforation with that post. So if I went in surgically, I would never be able to address that. This would never heal. And if you go in conventionally to retreat this, you want to know ahead of time and explain to the patient about this perforation so that you don't feel like you're backpedaling and saying, oh, by the way, that I tell you that there might have been a perforation, or, oh, I found a perforation. And this way you're safe in that you know that you didn't cause this, that this was already existent, and at least you made the patient aware of this. Here's a great case where the dentist, very good friend of mine, a great diagnostician, sent me this patient where you could see what looks like a little widening of the ligament, perhaps a small periapical lesion. And the dentist thought that this lesion was the source of the patient's discomfort and said that the patient either needs a retreatment of the root canal or possibly apical surgery. When I took the cone beam CT, you could see very small lesion, but look at this pocket on the lingual of this root. So if I would have done either a retreatment or an apico, I would not have solved the problem. With cases like this, when you see that lingual pocket, there could be a crack, and I'll talk about cracks in detail later on in my presentation, but this needs to be addressed, and maybe a deep curettage, and we could possibly look for a fracture by elevating, lifting the tissue back there lingually. And then if that still doesn't solve the problem, then we have the ability to also do conservative retreatment. And as Dr. Malia pointed out, look at this asymmetric radiolucency on the lingual aspect of that root, often indicative of a crack. This patient had really no symptoms, but the dentist was concerned and questioned what was that radiolucency around both those roots of that lower molar. Interesting enough, this is the patient's normal anatomy. If you look here in the 3D rendering, there's just a bony depression around these roots. And periapically, here we're focusing on a distal root. Here we're focusing on the meso root. The bone is completely intact. There is no pathology at all, just this bony depression. But you could see why the dentist was concerned due to the radiolucency there. This is fantastic. And a part of the benefit of having multiple offices, I have 6 great partners that I work with. All of them were my students previously at Penn. And I have to honestly say that they're better than me clinically. And I have this one partner, Dr. Eltom, who is a phenomenal clinician. He gets this case. This is a lower bicuspid. You could clearly see from the periapical film that there's a bifurcated root. In my opinion, these are more difficult than any molar that you could do. So Dr. Eltom does his first appointment, finds 2 canals, places calcium hydroxide, but throughout the appointment, he noticed when he got to this point here, there was more than just a bifurcation. He just didn't feel right, that maybe he was missing something. So after placing calcium hydroxide, which is the radio-opaque material here, he took a cone beam CT and look at the anatomy right here. The body is very symmetrical. So if you have this C-shaped root on this axial view and 2 canals were treated, this is not just going to be empty root space. There's going to actually be a 3rd canal or a trifurcated root, which he was able to find the 2nd appointment and treat. This is one of the most difficult possible root canals. Please don't send it to me. I hope you guys could do this, or somebody like Dr. Eltom. Even filling this, think about it. You'll have to place one, got to perch a cone, burn that cone apical to the split to make room to place the 2nd cone, burn that apical to that split to make room to place the 3rd cone. Very, very difficult case. Here's a case where the patient presented with a separated file. When the dentist was attempting to take out the separated file, had a 2nd separated instrument in trying to bypass the 1st, and sends me the case. Here's my final, but I want to show what the cone beam significance is. The cone beam is your GPS. It's your guidance to how you're going to treat cases like this. Separated files are very, very tricky. And the key to the CBCT right here is that I want to know on which wall these separated files are so that I could work on the inner wall in order to free up space. I know this is counterintuitive to a technique where we always say stay away from the thinner part of the furcation, go on the outer wall. But if you would open up the outer wall, you would end up with a secondary breakage, as possibly the patient, the previous dentist did, separated second file, or there's no room to be able to get that out. So first, I opened up with very thin ultrasonics on the inner wall, using the cone beam as my guidance, able to take out the smaller file, and then I had the larger piece of the file, and I was able to use this loop technique that's invented by my dear friend Yoshi Teriuchi from Japan in order to lasso that bigger piece and take that out. Now let's go on to cracked teeth. Dr. Malia did a great job introducing this. I see these every single day of practice. And as he pointed out, a lot of times you cannot see the cracks on the cone beam, but you're looking for certain patterns of bone loss. Other times you have the ability to see a crack. Now, this young boy came into the clinic at Penn, and he was wrestling with his cousin, and he fell and banged his tooth, and he has this horizontal root fracture. A young boy, it's way too soon to think about either taking out the tooth or even trying to avoid doing root canal, because when the fracture is so far apical, then you're hoping that this can stay vital and the tooth can continue to mature. We took a CT. Wait till you see this. It wasn't just a horizontal fracture, but the fracture was completely circumferential around this whole root. And how this changed our treatment plan is that if we just left it like this, then this would become necrotic and abscessed. The young boy would start to lose bone, and this would be a much, much more difficult procedure down the road. So unfortunately, when you see a fracture like this, you have to tell the parents that we're sorry, but he has to lose this tooth, and then he'll have a space maintainer or a flipper until he's old enough and mature enough to be able to get an implant. This one is fantastic. Patient was sent to me suspecting a fracture. Look at the arrows here. You make out something on the 2D film. You see another sense that maybe there is a vertical root fracture. We take the CT and look at this. I literally wrote wow when I sent the report to the dentist, because this is a radix or even fusion of a whole nother tooth and root attached to this tooth that you have no way of seeing from this. It looks totally normal on the 2D film, whereas look at this view right here where you have the molar and here's an extra root hanging off it. So something like this, one of my favorite CTs when there was a suspected fracture. A little trick, we use a bite stick or what's called a tooth sleuth, have the patient biting down, and upon release, if it hurts, then we suspect there could be a vertical root fracture. So when taking your CT, instead of having the patient biting on that little block when they're in the machine, you can actually have the patient biting on that bite stick or tooth sleuth and take the cone beam while they're biting on it, hoping to be able to show that separation of the tooth structure. And you could actually make out with these yellow arrows because the patient was biting down very hard for those 20 seconds that we were taking the CT. Of course, transillumination is shining a fiber optic from either the buccal, the lingual of the tooth, and if it's not transmitting to the other side, that's another determination of a fracture. This case, the patient came to my office. We see emergencies every day in private practice. You see it would look like the dentist, like a typical abscess on this tooth. Patient's in pain, asks us, please open up the tooth, do the root canal. Prior to doing or attempting or starting the root canal, when you see such a shallow restoration like this and the potential for maybe some bone loss here, we took a cone beam. And it's a good thing we took a cone beam because there is a vertical root fracture and the tooth is basically split in half, which means it has to be extracted. So we save the patient the problem of having to have root canal treatment done. And then if you didn't see a crack, saying, here's some medication, and patient continues to be in pain, or you get them numb, you open up the tooth, and then you see the fracture, whereas you can make this diagnosis and then send the patient to have the tooth extracted. This one wasn't so straightforward because the patient was referred thinking that the source of the problem was the mesial of this first molar, which definitely does have a lesion around it. But on further investigation and from the cone beam, actually the source of the acute pain was this split tooth fracture of the second molar. And you can see on each of these views how this tooth is split. And the pattern of bone loss, as Dr. Malia alluded to, is going up the entire side of the root, not just apically. So this tooth had to be extracted. Similar situation, patient, by the time they got to me, had gone to their dentist with pain, seen a neurologist. They couldn't figure out these virgin teeth here. And when we took the cone beam, this pattern was very interesting to me. Look how you see this bone loss going all the way up the distal of the second molar, and you can see that the tooth is actually split. The reason why we're able to see some images like this and diagnose the fracture is that there's not a lot of restorations in this patient's mouth to cause any kind of noise or scatter. Basically, these were virgin teeth. Now, what Dr. Malia kept on referring to is patterns of bone loss. And as I said, oftentimes you cannot see the fracture even on the cone beam, but look at the pattern of bone loss, not just apically, but coming up the whole side of that root. That in combination with the bone loss here, we call this a letter J-shaped lesion, an endoperio lesion. And if you want to be 100% sure, you can access the tooth, and you can clearly see here that there is a crack going down the entire axial wall. Sometimes you have to open up the tooth just to get the patient out of pain. And then when you see the fracture, you close it up. At least you know they'll be comfortable. You can take it out of occlusion and then refer to the oral surgeon. This is a dear friend of mine who's 60 years old and just has a very, very clean mouth, hardly any restorations. He comes in and he has some indiscriminate pain, just slight pain. I couldn't find anything. Less than 6 months later, he's like, Sam, this is really starting to bother me back here. I attempt to trace a fistula, and I could hardly get the gutta percha to go in. But look at this CBCT, and within 6 months, so another sign of potential cracks is that they lose bone very quickly. So the difference between here and here, and look at all this bone loss, is less than 6 months. And of course, this tooth needs to be extracted. This is tricky, where you're looking at this pattern of bone loss here. And I wish that I could say with confidence that when you see something like this, that it's a crack. But unfortunately, due to scatter, due to noise or artifact from other teeth and other restorations, you cannot often say, oh, look, there is a crack that we're seeing here. But we're looking at for patterns of bone loss to determine possibility plus deep pocketing. Now, here's a case where very easy to be fooled, upper bicuspid, and I'm looking at the level of the post, and this line ends right at the end of the root. When you're looking at the axial views and you see all this distortion or noise or artifact, and the lines go beyond the confines of the root, obviously you know these are not cracks. These are artifacts. When you see something right at the level of the post, and now I can probe a little bit here palatally, this is a nice indicator, and one of those cases where even with a crown and root canal filling, I was able to diagnose a fracture. Now, I get a lot of cases sent to me, even from other endodontists, to do apical surgery. And this particular case, the dentist was an older endodontist, didn't do apical surgery, did treatment on this first molar. It looks nice. He sends me a regular film. I took a digital film, but when I take the CBCT, you can see from the shape of this mesial root that there was another mesial buccal canal, known as an MB2 or mesial palatal canal. Now, here is the coronal view of this mesial root. So let's imagine I'm going to do a apical surgery. There's my Lindemann burr that I'm going to cut off 3 millimeters of this mesial buccal root. The problem is at 3 millimeters, I'm addressing the mesial buccal 1, but I'm barely touching the mesial buccal 2. Therefore, I'm going to have to go at a negative angle to get to that mesial buccal 2, and then to correct it so I could see it, plan it out. Now I'm sacrificing the crown root ratio. Therefore, I'm going to change my treatment plan from an apical surgery to a conventional retreatment. So the cone beam helped to change my treatment plan from originally was sent to me to do surgery, but instead I'm going to do conservative treatment. Now, here is a case where patient presents with very, very well done 4-canaled lower molar. In this particular office, so I have 4 offices, but only 3 cone beams because I don't have room in the oldest office. So I said to the patient, look, I'm probably going to want to do a surgery here, but before we commit to that, you need to go to one of my other offices and have a CT taken. And he has this cone beam taken. And let's first look here. You can see the mandibular canal fairly far away from this mesial root coming over to the mental foramen. But here's the importance. I'm about to show a video, and this is how I scroll through a cone beam. I'm not doing this now. This is how I do in my office, where as I move that blue line here, I'm looking here. And notice that the canal comes here, but then it circles back to the mesial root. And now as I'm scrolling here, looking right here on the cortical bone, that's where the entrance from the mental foramen is. So what's happening is the bundle is coming out through the mental foramen, circling right back to the base of that mesial root. I call a patient, I say, guess what? Too dangerous to do surgery. The cone beam has now changed my treatment plan, and I'm going to do a conventional retreatment. I just added this case, and this is so important because the patient had a very well done root canal done. She had trauma many years ago, had a retreatment done by an endodontist 2007, did a good job, a little bit of excess sealer. She goes to the endodontist that did the retreatment. He doesn't do surgeries that often. So he gave her a 50% success rate of surgery. So referred her to a periodontist who said, I'm going to do an extraction, graft, and implant. Now, anybody in the audience who does restorative dentistry knows this is a very difficult restorative procedure on a lovely young woman, anterior aesthetic zone, to extract this tooth and do a single tooth implant. You run the risk of losing the papilla here and having a terrible aesthetic result. So I said to her, look, let's do a cone beam. From the cone beam, here is this foreign body that was actually excess sealer. But look at the intact cortical bone she has and bone here. And I said to her, look, if I raise a flap and do surgery here and there's bone, you have like a 95% chance of success. If there is a fracture, you have a 0% chance of success. So I don't agree with the 50-50. It's almost all or none. I raised the flap, a lot of granulation tissue and some pus coming out. Shave the end of the root. There's leakage all around that gutta percha. That's easy to fix. I prepped that and filled with bioceramic putty. Place some grafting material, and that foreign body you could see here. Here's my scalpel blade, and that foreign body was a sealer that had gotten out through the apex from the retreatment and was living out in the tissue that I was able to remove. And here's my final X-ray. So tooth is very much savable, and look at all the intact. This is all intact, healthy cortical bone. Now let's talk about resorption, and you have internal and external resorption. Beauty of the cone beam, it shows very clearly here how you have the canal and now it balloons and then continues on here. This is a perfect example of internal resorption, and you could see the periphery of the entire root in a case like this. Much more often than that, we're getting external resorption. In this case, and 100% of the time when there's resorption, you have to take a cone beam because, as Dr. Malia pointed out, you can only see 2 dimensions from the radiograph. So you need to see the location, the extent of it. And in this case, it's on the cervical portion of the palatal above the bone. Therefore, I chose to do a surgical approach. When you go to remove this resorption, I know I'm going to be very close to the pulp. So I'm going to do the root canal first. Then I'm going to expose this area, clean out the resorptive defect, get clean margins, and place a Jerry Store restoration. What's very interesting is that the pulp doesn't want to be invaded by the resorption. And you're going to see cases like this, with the resorptions coming in from all around, yet look at this, the pulp is protecting itself. It's laying down thin layer of either predentin or tertiary dentin, and actually the resorption is coming in this way, coming in this way, coming this way, but still not invading the pulp. Look at this here. You can still make out the intact pulp. Now, of course, if the tooth is restorable and you plan on going in and removing that defect, you have to do the root canal first because you don't want to leave any of those cells from the resorption. This is great. This is an 18-year-old patient. He came in. I was able to get an old 4-year-old Panorex. He had a severe crossbite. He had his braces on for over 4 years. Tooth is vital. The 2D film shows this resorption defect, but look at this view here. This is what I love. Let's make out the pulp. The nerve canal is going like this. See that? And here is that defect, yet the pulp is still protecting itself right here. Now, of course, if we're going to go in and excavate that, you have to do the root canal first, because the last thing you want to do is leave any potential cells from the resorption. This patient came to see me. He's 37 years old. He had trauma when he was a kid 30 years ago, and basically has this arrested resorption. This is ankylosis, meaning bone is replacing that root. And as you could see here, there's very little root left. There still is some vital tissue, believe it or not, right here. So if you put ice on the coronal aspect of the tooth, patient feels it. It's vital. Now, what are you going to do here? Of course, I'm not going to excavate this. The patient aesthetically looks fine, but basically at some point in time, he's going to bite into a hard sandwich or pretzel and end up without this tooth. And then he's going to need to get a implant there. This saved me because the patient came in for tooth number 2, this upper second molar, and I see this impacted third molar. He's symptomatic. I'm about to do the root canal where I have to open up the tooth. It's necrotic. I'm going to do a lot of irrigation with sodium hypochlorite. Thankfully, I take the CT and look at how this root is exposed here and perforated right here, that if I tried to do my access and use sodium hypochlorite, it would get out into the soft tissue, and that'd be very uncomfortable for the patient. So this tooth had to go, unfortunately, straight to extraction. Last topic here is using CT for outcome studies. We came up with our 3D, the Penn 3D healing, and my favorite topic is this one, which is called limited healing, where we go in surgically and we do our apicalectomy. Patient comes back for recall, and you see that there is now a continuity of the cortical plates, meaning initially there is this triangle-shaped osteotomy that's cut in order to access the root, and now it's starting to heal in, but there still is an area of low density. Or you have low density area means completely asymmetric, meaning you can make out that pie shape or triangle shape osteotomy, but it's definitely in a healing phase. How about this, where the bone starts to fill in and the bone starts to fill in at the apex, but doesn't fully form, and there still is a break in the cortical plate. This is the most interesting one. I'm going to show you this case in conclusion, is that you would think the last to heal is the cortical bone. That's the most difficult part to get to heal. Yet in this case, the cortical bone fills in, but then the bone is not fully filled in at the end of the root. And we refer to all these as limited healing. So my final case, let me share this with you. Great patient came in with a lesion going up this mesial root, as well as a small lesion around the distal. When you look at the shape here, I was concerned about possible vertical root fracture. I chose to go in surgically, did an apicoectomy. As I resected the mesial root, we have mesial buccal, mesial lingual, mid-mesial, and this was a question mark. I couldn't see whether this was a vertical fracture or not, but I see this J-shaped lesion, as I'm talking about, going up into the furcation. I completed the bioceramic root end filling on mesiobuccal, mesiolingual isthmus, distal buccal, distal lingual, and you can see up in here, which is where I did not necessarily see a crack, but I was worried. I packed some grafting material there. here's my post-op, 7-month, 13-month, 25-month, 37-month, but let's look at the CT. Here we have a focus first on the distal and the distal root at 3 years post-op, complete reformation of the cortical bone, slight change in density, but I want to focus on the mesial. The mesial had this large lesion, did the apical surgery. In comparing this at 3 years, you could see nice bone fill here, but this is the part that perplexes yet excites me, where the cortical bone has regenerated, but what's this here? Is this some woven bone, meaning there is some bone filling in, but just not mature yet? Is this a mix of bone with some granulation tissue? Hopefully the case is not failing, but we're failing, then I would suspect that the cortical bone would not have filled in. So with that, I want to thank you very much for your patience. And when I'm not giving lectures or doing root canals, I'm a professional bartender, and this is the bar at my house right off my kitchen. So this was my COVID hangout. And the best thing about this is it's open 24 hours a day because it's right in my house. So there's the daytime view. Thank you very much. Dr. Malia, could you, do you want to answer this question about the KVP?
Sure. So, so the question was, should the clinician adjust the KVP, MA, or resolution settings? So typically for resolution settings, you don't have to. You keep it the smallest field of view, and that should be good. You can adjust the KV and MA, and you should do that, especially if you have a patient who has more restorations or a patient who might be a little larger. You want to have the KV MA be higher so that you have more photons going in, you have more signal, and you know, a better image in that regard. But that said, with the artifacts that you'll get from metal and often with the gutta percha, especially when they are robust, there might be, you know, a little that you can do to get rid of those artifacts, even with increasing the KV or the MA.
I'll take the next question. Thank you. The compliment, it says phenomenal cases. Do you routinely charge for CBCT? The answer is yes. Routinely I do. But if it's a case where I need to take a cone beam mid-treatment, let's say I cannot find the canal, or when I do recalls, I do not charge the patient, and it's very case specific. If the patient knows ahead of time we plan on taking a cone beam, then we'll quote them a fee. I'm not embarrassed to say so. I charge $180 for CBCT. Dr. Malia shared the code with you. I find that not a lot of insurance companies pay for that, so we'll often ask the patient to say to pay for the cone beam up front, and then if the insurance company pays anything, of course, we'll reimburse the patient. But I take them plenty of times for free if I really want to see something, or if there's any question or the patient is hesitating and I want it, then I'll just take it for free.
The next question that was asked was, is it possible to distinguish between a residual cyst and incomplete healing with CBCT? And perhaps Dr. Katchman can also add to this. But I think that, you know, that distinction, I think, will come a lot more with the clinical presentation of the patient. So in other words, you could have a patient who might have a radiolucent area that might be nicely corticated, but unless it has a shape that suggests it's cystic and it's expanding. If the question is, you know, just an area of radiolucency under the apex, do we think it's a residual inflammation or incomplete healing or a residual cyst? You know, I think it really depends more on the clinical symptoms. If the patient is clinically symptomatic, then you would start thinking more of residual inflammation. But if there's not symptomatic, then perhaps start thinking of incomplete or yet healing. Perhaps Dr. Katchman can add to that.
Well, yeah, I agree with you, Dr. Malia, but the very simply with our residents, we tell them, please don't use the word cyst. You could
Yes.
say something like a cyst-like appearance, but really you have to biopsy. So in cases that we're unsure of, when we go in surgically, we'll simply take a sample and biopsy. And I think we all agree that that is the only way of distinguishing truly between a cyst and a granuloma.
True. I agree with that too. Yes.
And I think maybe Dr. Malia could answer this last question: is when will it be considered the standard of
Standard
care?
of care. Yeah. So standard of care as a term really is more, legal kind of definition. But to get to the point of, will if you see the current AAE, AAOMR recommendations, the first one, recommendation one, indicates that periapical radiography should be the initial assessment. And I think one way to think about this is that yes, I mean, CT is definitely providing value, but I think those guidelines were sort of written to make sure that that entire marketplace goes through, and there is more access to CBCT, or else somebody who does not have access to CBCT could be sort of quote unquote being under the standard of care, right? But another way to think about this is that yes, already I think in some situations, the situations that we described today, the cases that Dr. Katchman described, for those cases, let's say if you were to operate purely under a periapical, and then you did get into some complications, and then those complications were investigated either by a dental board or, for that matter, by a legal group. Then the question would be asked as to why did you not take a CBCT? Because I think currently there is a lot of evidence that shows that there is value for that CT imaging in diagnosis and treatment planning. I think it's so in a situation where I guess, especially in your community, especially if there are a lot more individuals who are using CT, then clearly I think you could be viewed as somebody who did not use the technology when it could be used. Yeah,
that's a great point. And just finally, having somebody like Dr. Malia to be able to view your cone beam is very important. And it's a very long discussion. We don't have time for it tonight, but I'm not a trained radiologist. I'm an endodontist, and I know most of the time what I'm looking at, but all the time I bring my cone beams to the radiology department at Penn to have a professional view them, somebody like Dr. Malia. So that's important, and that could cause some legal issues if something is missed by a practicing dentist or endodontist, and God forbid the patient has something maybe even non-odontogenic that would have showed up that I wasn't able to interpret properly on a cone beam. But I think that's for a whole nother discussion.